Dr. Vaziri is the founder and CEO of Biosensics, a biomedical firm focused on development of wearable sensors and digital technologies for clinical trials and health outcomes. Dr. Vaziri, thank you so much for being here.
It's my great pleasure. Thanks everyone for your time. And it's a pleasure to be able to present some of our work related to developing technologies for health outcome assessments and measurements of disease progression in different therapeutic areas, with obviously a focus on our work in Huntington disease. So a bit about the history of our company. I founded the company back in 2007 when I was a research faculty at Harvard. Since then, we have received close to $50 million of funding from National Institute of Health, developed 3 FDA-registered Class II medical devices. We also developed a fall detection technology that is the gold standard in the United States market, and it's also used globally in many different countries. In August 2019, we had a very successful transaction with Best Buy. This was very exciting for our small company. Also, we were excited to see that based on this transaction, the impact of the technologies that we have developed would extend to larger community. Our success story has been featured by the National Institute of Health as a cover story related to the success of some of the programs that they fund. We were honored also to receive in 2020 the Tippett Award from the United States Small Business Administration as essentially one of the most innovative companies in the country. So moving on, my presentation is mainly focused on our technologies related to assessment of health and also monitoring disease progression, and also showing results specifically related to our studies in Huntington's disease. At the very end also, I would like to mention briefly an exciting new platform that we are developing for care coordination and facilitating care management. So with regards to the technologies that we currently offer and developed, you can see it in this slide, Gait and Balance, where we offer and provide devices for quick objective assessments of gait and balance. With regards to physical activity monitoring, we have a very advanced sensor solution that not only monitors number of steps like any other fitness sensor, but also it can monitor postural transition, gait and gait parameters during activities of daily living, and it can monitor also falls. Motor symptoms, we offer solutions for continuous assessment and monitoring of motor symptoms such as tremor in Parkinson's disease and chorea in Huntington's disease. Voice biomarker, where we offer solutions for collection and analysis of voice, for example, for analyzing dysarthria in Huntington disease. And we also have a solution for collection of patient-reported outcomes. So the key concept behind our solutions is to integrate them into a single system in a way that using a single system that is given to patients, we would be able to monitor a wide range of digital biomarkers related to multiple clinical domains. And this is obviously critical, for example, in a disease like Huntington disease, where there are multiple symptoms and multiple clinical domains that get affected. And you will see the application of this in the next few slides in Huntington's disease. So just to show you how the system looks like, this is the system for monitoring participants and patients at home. Essentially, we have sensors that are worn by the participant. In this case, it's on the wrist, and it does monitor, for example, the chorea of the participant continuously and chorea level. We also have a mobile and mHealth applications that run on tablet or phone, and it enables collection of wide range of endpoints and biomarkers. So just to show you an example of what can be collected using this, this system, in addition to the sensors that are provided, this is actually an example from ALS, a study in ALS, where you can see that there are multiple indications and multiple symptoms that are monitored using the system. So not only reporting falls and near falls, but also data related to speech and voice is collected using the system. Handwriting and pattern tracing are other domains that are impacted by ALS. And again, using the system, we would enable collection of that data at participants' home at very high frequency. So I thought it might be interesting just to look at, for example, some of the tests on their pattern tracing. Some of them actually could be relevant to Huntington as well. There are 4 different tests that are performed in that specific study, which is in collaboration with Penn State Medical School. This is, for example, drawing a clock, which also has cognitive components. And the other one is following a spiral using on the tablet. I would like to, again, highlight the support from NIH. Again, we've been very honored to receive multiple fundings from National Institute of Health to perform large-scale observational studies in different therapeutic areas. Specifically, we currently have 4 large observational studies, one in Huntington disease, and the other one, I did 2 on Alzheimer's and one in myasthenia gravis. With regards to our Huntington disease study, we have currently following 44 participants for over 2 years, and we have monitored their physical activity, speech, chorea severity, and and also clinical scores over these 2 years. So this data set, which I will present in the next few slides, actually represents the largest data set on digital biomarkers of Huntington disease that ever has been collected. So now switching to our work specifically in Huntington, just some background, as I guess most of us know, Huntington is a multifaceted disease that impacts motor, cognitive, and includes psychiatric symptoms. The way it is measured currently is using a standard method called Unified Huntington Disease Rating Scale, UHDRS. And based on our results and other results presented into literature, there is an unmet need in development of better, more sensitive, and digital methods to assess the progression of the disease. This was really the motivation behind our study. And one more thing that I want to say is also to be able to monitor and detect symptoms at earlier stage and prodromal stage of Huntington disease, which is again another unmet need in this area. So I want to start with the pilot study that we performed here. This was in collaboration with Auspex Pharmaceutical, started back in 2012, I believe. The company was acquired by Teva, and we completed this study in collaboration with Teva at that point. So in this study, what you see actually in this slide, in this image, is the very old version of the device going back to about 10 years. We had a relatively robust study design. The individual 20 participants came to the clinic. We did all clinical assessments. They wore actually 5 sensors at home for 1 day, and then continued once to bear 1 sensor on the chest for additional 6 days, for a total of 7 days of monitoring. So with our technology, we were able to fully analyze their physical activity at the home environment. So for example, this is an actual result from a HT participant. You can see that during the period of monitoring, we could distinguish walking, standing, running, which there was no running in this case, and lying. And we could also look at how those results are different from control participants to HD. Now, based on the results of our analysis, this is, by the way, published in 2016 in Journal of Huntington Disease, and this was in collaboration with Ray Dorsey at the University of Rochester. Let me see actually if I can expand. Okay, this is much better. Yeah, so you can see that in this study, we have shown that walking parameters such as cadence and cadence variability are sensitive to HD severity. So specifically, we analyzed the data based on the data collected from control HD with total motor score of under 50 and total motor score of above 50. And for example, if I look at the cadence here, you can see the results compared for three different groups between this is control, this is HD with a score of under 50, and this is HD with a score of above 50. And the stars that you see is whether that parameter by itself is sensitive. So for example, when I look at a step time variability, actually you can see that the results are quite sensitive to that parameter. But when I look at cadence itself, only when it's collected at home, we have actually sensitivity in this case. So based on this very interesting results, we actually started another. We managed to secure $2.5 million from funding from NIH. This is again in collaboration with Ray Dorsey and University of Rochester to perform a much broader and much longer duration-wise study in Huntington disease. And not only, so the previous study was limited to sensor biomarkers, we also collected the speech data and we collected data from the patient-reported outcome. So this is how the system looks like. You know, I showed an image before. So the participants wear a sensor on their dominant wrist for chorea detection, a sensor around their neck for physical activity monitoring, and voice captured cognitive tasks and EPRO are collected using the tablet that we provided to each participant. So just looking at the baseline characteristics, we recruited 12 control, 9 prodromal, and 23 HD participants. And you can see actually some of the baseline clinical characteristics in this slide. Now, I think that here I'm going to show you to start. I'm going to start showing you some of our results, which I believe are quite interesting. So the results shown here is actually up to 12 months of monitoring. We have not fully analyzed the data after 12 months of monitoring at this point. And the data shows over 1,600 days of monitoring of participants, continuous monitoring of participants in this study. So the result here, this is total UHDRS score. And if you can see between the three groups, essentially what is important here is to look at the p-value. If the p-value is close to 0, it means that that parameter essentially is sensitive. So you can see actually when we look at UHDRS, really there is no change in any of the groups during the 12 months. And this is well known in the literature. Essentially, what is well known is Huntington in general is considered a slow progressing disease, at least when it's measured using the current gold standard, which is UHDRS. But now the result from a very simple activity monitoring parameter, which is the steps per day, when we compare the results, now you can see that actually this sensor-based parameter can essentially detect the progression of the disease, is sensitive from in 12 months to actually detect some changes, at least in disease progression. So we also looked at falls. My understanding, I'm an engineer, but based on what our discussions with our collaborators, falls are not considered to be a very critical, concern in Huntington disease. In Parkinson, for example, it is known Parkinson patients to be much more vulnerable to falls. But our data, which by the way is based on objective measurements, is quite contrary. So you can see actually this is falls per week. In the control, we had 0.05. So every 20 weeks, essentially, there was one fall. In Huntington disease, whether Huntington patients who were on medication or no medication, the rate of falls was about 10 times of control. And also, what was interesting is near falls. We had many near falls reported. This was not captured by the sensor; it was reported by the participants. So many falls reported in AHD with no medication. I have to say that this is a relatively a small study size for looking into, for example, the prevalence of falls, but this at least preliminary data shows that perhaps monitoring falls are important in HD. As the last part, we looked at also speech, and the end goal here is to develop a system to be able to automatically analyze each speech and essentially speech deterioration in Huntington and other diseases. So at the end, we would like to have a system that, for example, gives a score for dysarthria as the disease progresses. So I'm going to show you results for two different speech tasks. One of them is reading a passage, and the other one is counting. There are two different types of speech parameters. One of them are classical or traditional parameters, and those are the ones that you see here, which essentially if somebody listens to you and can monitor these parameters. The next slide are actually looking at the characteristics of the signal using computer algorithms. So those are parameters that can be only captured using technologies such as ours and really cannot be assessed in the clinic. So these traditional speech parameters, again, the P is what is important, and you can see that at least at this point, at least based on data, when we look at control prodromal and HD, these parameters are quite sensitive in differentiating or distinguishing the three groups. So, for example, the p-value of 0, the ones that are bold, it shows that a specific parameter can differentiate the two groups. When we look at computerized parameters of speech, again, the same story. So individual parameters, in some cases at least, are sensitive. So this shows promise in developing a system that essentially at the end can provide that quick objective assessment of the speech. So as a first phase of doing so, we looked at actually, we looked into those parameters as a function of this arteria score as rated in the clinic. So we had 19 individuals with the rating of 0, 10 with 1, and 4 with the rating of 2 or above. And then we look at how those parameters can differentiate patients based on this arteria score, which again, the results are very interesting and promising because it shows that even a single parameter at least can differentiate different groups. Now, same for computerized assessments. So again, we are working at this point to creating the model that I mentioned to be able to automatically score a speech characteristic and dysarthria score just using the data collected using your phone or your tablet. I just want to briefly mention a separate product line that we are working on. This is scheduled to be released in Q3. This is actually a care coordination solution, which should facilitate care management and coordination of care between what we call a care circle, essentially, family and friends who provide care or who manage care for a loved one. So the system includes an app that is used by the care circle, and again, another app that is used by the patient or the individual who needs care to manage different tasks related to their everyday life, their appointments, their medications, and coordination of care. So At the end, I just want to acknowledge again the funding from National Institute of Health through different agencies within National Institute of Health, as well as our active collaborators in many top universities. Thank you very much for your attention.